Good afternoon. I'm Pierluigi Porcu from The Ohio State University. My talk is on diagnosis and staging of cutaneous T-cell lymphoma. First, an outline of the presentation. We're going to go through some of the fundamentals of the diagnosis and classification of lymphoma in general, how the classification of lymphoma evolved. I'm going to give an example of a classification of lymphoma that may appear to fit one category, but in reality fits a different category. We're going to discuss the specifics of diagnosis and classifying and staging cutaneous T-cell lymphoma. I'm going to give you some outline of the foundations of staging and why do we do it. We're going to review some of the terminology that your doctor may use during your visit and in follow-ups. And then finally, why stage is important for mycosis fungoides. First, the basics of diagnosis. What diagnosis means is discovering and classifying a disease. Discovery means find it so that you can treat it. And classifying means name it so that you can know exactly what it is and then again treat it. There's an inheriting conflict between discovering and classifying disease. It's better to discovering early as opposed to late, and classifying it, obviously you want to classify right versus classifying it wrong. Sometimes it may take time to actually have a exact classification of the disease. Early diagnosis means a better outcome and possibly prevention strategies. The correct classification essentially offers the possibility of universal language and communication among providers, knowing what to expect from the disease, learning how to find and treat it. This loops back to early diagnosis because once you have an idea of how the disease behaves and how to recognize it, then you can go back and make a diagnosis early. The beginning of the terminology in lymphoma goes back to this physician, Thomas Hodgkin, who was a British physician from the 1800s who discovered and described Hodgkin's lymphoma for the first time. Another physician who made important discoveries in Hodgkin's lymphoma is Dr. Dorothy Reed, who's a physician, an American physician, who discovered the cells that clearly make a specific diagnosis of Hodgkin's. The cells are shown here in the slides with the black arrows. Any lymphoma that has those cells would be called Hodgkin's lymphoma, and any lymphoma that doesn't have those cells will be called non-Hodgkin's lymphoma. So this made for the first time the distinction between Hodgkin's lymphoma on one hand and non-Hodgkin's lymphoma on the other hand. At the same time, this illustrates the fact that non-Hodgkin lymphoma is really not a specific diagnosis, and essentially the Hodgkin cells really represent the first biomarker for lymphoma. We now know that lymphomas are malignancies that develop from the cancerous transformation of lymphocytes, and these lymphocytes are shown here in this slide on your left. And there are many different types of lymphocytes, fundamentally three main types, B cells, T cells, and natural killer cells. With this information, therefore, we can now classify lymphomas as B cell lymphomas, T cell lymphomas, and natural killer cell lymphomas. We also know that the lymphatic system is a diffuse, organized tissue across the body, which is made of a network of vessels and lymph nodes with some main organs that represent the main stations of the lymphatic system. Those are named in the slide: the bone marrow, the thymus, the lymph nodes, the spleen, and the tonsils and the adenoids. We also know that lymphocytes normally traffic across the body. Typically, they do that through the bloodstream, and they populate the digestive tract, the respiratory system, and the skin. Therefore, lymphomas may not develop only from cells that are located in some of the main lymphoid organs, such as the bone marrow, the lymph nodes, and the spleen, but they also develop in the respiratory system, in the digestive tract, and in the skin. Besides the classification in Hodgkin's and non-Hodgkin's, therefore, as the slide illustrates, there is a whole list of different types of B-cell lymphomas, of T and NK cell lymphomas, and then there are some mixed types of lymphoma where you have composite B and T cell, or different types of T, a different type of B cell. This slide shows the current classification of T-cell lymphoma, and the group of lymphoma that we are mostly interested today is right there in the red square on your right. One important consideration to make in this classification is that the clinical features of the lymphoma are actually very important in distinguishing different families and in helping the diagnosis. You can see that depending on the clinical presentation, we have some T-cell lymphomas that present mostly with leukemic peripheral blood involvement. Some of them present mostly with lymphnodal involvement, some of them extranodal involvement, and then finally the skin. The fact that the skin lymphomas are classified as an independent category here shows the fact that they are recognized as a very particular type of lymphoma with a different behavior from the other ones. This slide is going to give you a visual representation of the frequency of cutaneous lymphomas in the context of all the other types of lymphomas. Every year, there are about 78 to 8,000 cases of lymphoma diagnosed in the United States. Of those, a minority are represented by Hodgkin's lymphoma, and the rest are non-Hodgkin's lymphoma. As we already discussed, many of the non-Hodgkin lymphomas are B-cell lymphomas. The rest are T-cell lymphomas, and then a very small group of natural killer cell lymphoma and other types. Within the T-cell lymphomas, about 80% of the lymphomas are called the peripheral T-cell lymphomas, and the rest are called cutaneous T-cell lymphomas. There's a small minority of B-cell lymphomas that affect the skin that are called cutaneous B-cell lymphomas. And then finally, there's a small group of non-T and non-B cutaneous lymphomas that are shown right there. Of the cutaneous T-cell lymphomas, the majority are mycosis fungoides and Sézary syndrome, and the minority of the cases are called non-mycosis fungoides or Sézary syndrome. These are represented for the most part by the CD30 positive lymphoproliferative disorders. The two arrows here are showing that small corner square right there in the right corner is what represents the cutaneous lymphoma, which therefore is just a small minority of all the types of lymphomas. I'm going to illustrate a case here to show you that this presentation in the skin with T-cell lymphoma does not necessarily represent cutaneous T-cell lymphoma. This is a 66-year-old gentleman who presented to his dermatologist with some erythematous nodules in the skin, which are shown in the slide. A biopsy was done and is illustrated here. In the center of the slide, you see a section of the biopsy with a lot of inflammatory infiltrate, which is represented by the black and blue dots. And you can see that the blue and black dots are really deep. They go from the surface of the skin all the way to the deeper layers. At higher power, which is in the panel to your left, upper panel, the cells are very large and highly atypical and irregular. Some immunostains were done which show that the cells are positive for CD30 and for CD4, therefore are T cells that express CD30. And because of the expression of CD30, the ALK1 stain was done, which is negative. The interpretation from the pathologist here shows that this is an abnormal biopsy, most likely consistent with a T-cell lymphoma, but the infiltrate of the cancer cells is deep, is not epidermotropic, that is, it does not affect only the upper layers of the skin. The cells are highly atypical and large, and they express CD4. The expression of the other markers is listed and noted. Finally, the diagnosis here is findings consistent with a T-cell lymphoma involving the skin, but clinical correlation is suggested. This means that the physician has to provide additional clinical information to the pathologist, or at least the pathology has to be interpreted in the context of the clinical presentation of the patient, including the physical examination, the laboratory test, and any additional imaging that needs to be done. In this particular case, the patient went through complete physical examination showing that the only nodules were in the skin, but the LDH, which is a laboratory test which is frequently run in lymphoma, was elevated, which would be unusual for cutaneous T-cell lymphoma. The bone marrow biopsy was negative, but a PET CT scan showed the presence of lymphadenopathy in both axillae on the right and the left. It is illustrated by those bright yellow dots on the slide. Therefore, the diagnostic conclusion here is that the patient has peripheral T-cell lymphoma, not CTCL or mycosis fungoides. How about then mycosis fungoides? How do we make a diagnosis? From a clinical standpoint, the typical presentation is in an average age of 50 years or older, often with many years of skin rash, whether diagnosed with skin biopsies or not. Frequently, the skin lesions are in the form of what we call patch or plaque. Patches are spot, flat, red, and scaly, and patches are thicker that have some filling to it. Often the lesions are sharply bordered, erythematous, and scaly. The distribution of the lesions is in what we call bathing trunk, so it tends to affect the upper thighs, the buttocks, the lower part of the abdomen. The lesions may or may not be itching, and often there's a history of improvement of the rash during the summer, which corresponds to greater sun exposure. The slide illustrates some of the typical lesions for MF with sharp borders affecting, again, some of the not sun-exposed areas. This slide shows the remaining typical lesions that are seen in patients with MF. On the left upper panel, patches. On the right upper panel, there is a lesion that is called a plaque. The left lower panel shows a typical tumor lesion, and the right lower panel shows what we call erythroderma. This also corresponds to the staging category for the tumor part of the staging classification, with patch and plaque less than 10% of the body surface representing T1. T2 is considered patch and plaque more than 10%. The tumor lesions are classified as T3, and the erythroderma is classified as T4. From the standpoint of the diagnostic biopsy, as already mentioned to some degree in the previous slides, the skin biopsy should show an abnormally high number of lymphocytes in the skin with an atypical morphology, but not large cells. The cells tend to be small. There should be epidermotropism, and therefore the infiltrate is not as deep as the one showed in the previous slides, but should just be limited to the top uppermost part of the skin. The lesion may show something called Potrier's macroabscesses, which are particular clustering of lymphocytes in the upper part of the skin. And when we do a immunohistochemistry analysis looking at what type of lymphocytes are in the skin, it will show that the cells are CD3 positive, CD4 positive, CD7 negative. Finally, there is a molecular component of the diagnosis, which is represented by the analysis of the T-cell receptor gene, beta or gamma, and it is an adjuvant finding to see that the T-cell receptor is so-called monoclonal. It should be pointed out that the presence of a monoclonal T-cell receptor rearrangement in a skin biopsy per se does not represent a diagnosis of lymphoma, and that finding should be interpreted in the context of all the other pathological findings as well as the clinical presentation of the patient. So this slide shows in the left upper panel a figure of the normal skin with the black square representing essentially what we see on the punch skin biopsy. On the right upper panel, the biopsy is now stained with conventional H&E, which means a generic stain showing the individual cells and the distribution of the cells in the tissues. As you can see in this particular panel, most of the blue and black small dots are concentrated in the uppermost part of the skin, and within the epidermis, which is the reddish part of the skin biopsy, there are some clusters of cells that appear as white, and those are the Potrier's macroabscesses. The left lower panel just shows the distribution of the special stains, looking at expression of some of the markers for T cells, CD4, CD8, and so on. And the right lower panel finally shows a spike, what we call a spike or peak of analysis of the T-cell receptor, indicating that there is a dominant population of cells which are all identical and we call monoclonal. This slide shows why the diagnosis of MF is difficult in early stages versus more advanced stages. If you look at the panel, the upper panel where skin is listed, you will see that in the early stages that we call stage 1 and 2, most of the lymphocytes that infiltrate the skins are actually inflammatory, reactive CD8 positive lymphocytes, and the tumor cells, which are CD4 positive, actually represent a minority of the cells. Therefore, they're very difficult to find. There is a lot of inflammatory infiltrate, non-specific changes, and people may have to go through multiple biopsies before all the features diagnostic of MF are found, including the presence of a monoclonal T-cell receptor gene rearrangement analysis. On the right side of the slide, you see the distribution of the cells in the skin in the more advanced stages, where now the malignant cells, CD4 positive, represent the majority of the cells found in the skin. In that case, much more likely to the diagnosis to be made. The T-cell receptor analysis is much more likely to come back monoclonal, and also from the clinical standpoint, the lesions in the skin of the patient are going to be much more clear and diagnostic. Finally, I want to mention a particular type of marker that has become quite important in the classification of cutaneous T-cell lymphoma, that is called the CD30. This marker is important because there is a specific agent that is approved by the FDA now for treatment of lymphomas that express CD30, specifically anaplastic large cell lymphoma and Hodgkin's lymphoma. The use of this drug in cutaneous T-cell lymphoma expressing CD30 is still considered investigational, but the drug is very promising and is undergoing clinical trials. Let's move on now to the staging and the fundamentals of the terminology for staging. Staging essentially means mapping cancer in the body. You want to know how much of cancer there is. In the case of CTCL, for example, that could be expressed by what percentage of the skin body surface is affected. In other types of lymphoma, it could be how many lymph nodes in the body are involved, what the size of the lymph nodes, and what the so-called bulkiest lymph node or mass is. And finally, we also have some blood work, which I mentioned in one of the previous slides, LDH, which could be elevated in cases of lymphomas that are more rapidly proliferating. We also want to know where the disease is. In general, in lymphoma, we want to know if the lymphoma is localized or disseminated, whether the bone marrow and the blood is involved, whether the brain and the nervous system is involved, the skin, the lungs, or other organs. Now, why do we want to do that? We want to do that for a number of reasons. One is that staging, to some degree, defines a risk. In other words, defines a survival, probability of response to treatment, and other clinical features that may be important in counseling the patient as to the natural history of the disease. Staging is also important because we want to find out all the areas of the body that are involved with lymphoma so that after treatment we can assess response in the proper way. Every area that is involved with lymphoma will have to be proven to be now clear for the patient to be classified as a complete responder. Finally, we also want to know what the main areas of disease are so that on follow-up we can pay specific attention to some of the areas. For example, if somebody has lymphoma affecting the gastrointestinal tract, in follow-up some special tests may be necessary in addition to the general CAT scans or PET scans, such as a colonoscopy or any other endoscopic procedure. Finally, finding out about specific locations like the brain and the CNS may be important to plan therapy in a slightly different way. This slide shows what we call the canonical stage progression in most common cancers, which goes from stage 0, extremely localized, minimal in situ disease, to stage 1, 2, 3, and 4. The important thing to remember is that for different cancers, the time that is required to move on from stage 0 to stage 4 could be very different. In some malignancies, you can move on from stage 0 to stage 4 over a matter of months. In other cases, years, decades. And then finally, there are some malignancies that may actually not transition from early stage to advanced stage. On average, lymphomas that we call indolent or not aggressive tend to go through these different staging phases over a very long period of time. I also want to point out an important difference in the way we look at staging in common malignancies we call solid tumors such as lung cancer, breast cancer, prostate cancer, and blood-related cancers like lymphoma and myeloma. In lung, breast, and prostate cancer, surgery and radiation are really the fundamental modality of therapy initially. And therefore, the definition of cure with those two modalities is heavily dependent on stage. So if you have stage 1, cure with surgery or radiation is very likely. If you have stage 2, it is probable. Stage 3, highly unlikely. And in stage 4, definitely not achievable. On the other hand, in blood-related cancers such as lymphoma, myeloma, and leukemia, this correlation is really not existent. And therefore, the probability of cure with chemotherapy really depends on specifically what type of lymphoma you have. So as far as the definition of terminology, I want to describe briefly for you the distinction between indolent, aggressive, high-grade, and low-grade disease in lymphoma. So indolent means a cancer that grows slowly. Treatment may not be necessary, particularly with stable disease, and these malignancies are typically not curable. Aggressive, on the other hand, is a clinical term that indicates that the cancer is growing rapidly. Treatment is always necessary for survival, and these patients are often curable. From the standpoint of the pathology, which is reviewed on biopsy, we distinguish low-grade and high-grade or high-intermediate grade lymphomas. Low-grade, the cancer cells look small and monotonous. Most of them are resting, and in high-grade, the cancer cells typically look ugly, large. Most of them are dividing and growing. Additional keywords that we use in the treatment of lymphoma as other cancers are remission, which is a cancer that is not detectable at the end of treatment, cure, a cancer that never comes back after going into remission. Relapse is when the cancer comes back after the remission. Survival is defined as the time that how long the patient live after diagnosis, and progression, the cancer starts growing after a period of being static. I want to illustrate in a couple of slides the definition of cure so that it is clear how some of the so-called survival curves can be interpreted in the subsequent slides. On this graph, on the y-axis you have the percentage of patients in remission, and on the x-axis you have time in years. Now imagine a particular type of lymphoma that we're going to call A, that shows at the end of treatment the patients are all in remission, and over a period of 2 years there's a gradual drop in the patients in remission, with many patients relapsing. This drop in remission seems to hit a point where it stabilizes around 50% and at 2 years, and after that time point, moving forward, there are no subsequent relapses. We call this lymphoma curable because it's a flat tail, essentially, or plateau of the curve. In this particular case, the cure rate is estimated about 50%. The next curve shows lymphoma B, where essentially you see a similar pattern, except that the plateau occurs at a higher level. So this is a lymphoma that has a cure rate of about 75–80%. Finally, lymphoma that we are going to call C still has a plateau, but the plateau actually occurs on a much lower level, in this case about 25%. So I want to point out, because both A, B, and C lymphomas here are all curable, but the cure rate is different. So we're going to call lymphoma B as highly curable. Lymphoma A is going to be curable in about half of the patients, and lymphoma C is still curable, but in a small minority of the cases. So how does a lymphoma that is not curable look like on this type of curve? Well, essentially it's a continuous downslope gradually over time. In this particular case, it may happen over about 10 years, where no matter how long the patient is followed, the group of patients is followed, their continuous relapses are going to be seen. So putting together the graphs, essentially this shows that as long as you see a plateau, the lymphoma is curable, even if the cure rate may be as low as 15%. On the other hand, if you have a continuous downslope of the curve, the lymphoma is not curable. Most of the low-grade lymphomas, including CTCL and mycosis fungoides, belong to the non-curable type of indolent lymphomas. Couple of slides on the natural course of the disease in aggressive lymphomas and in indolent lymphomas. The first slide is on the aggressive lymphomas. The patient starts with an initial diagnosis and staging. Then there is sometimes an interim analysis of the response while the patient is going so-called induction treatment. At the end of the treatment, the patient is restaged, and all the sites of disease are analyzed again to make sure that the visible, so-called measurable disease is gone. Then there is a period of follow-up, or in some cases, maintenance therapy, although in aggressive lymphoma that is not done typically. And if you go past a certain window of time without any evidence of relapse, as shown in some of the previous slides, then essentially you have achieved a cure. Typically it takes about 3 to 5 years. The lymphoma may come back later, in which case is a relapse and the patient has to go through additional staging, retreatment, and often the lymphoma can be responsive, but in cases may not be responsive. On the other hand, a indolent or chronic lymphoma, the patient goes through the usual staging and diagnosing phases. Treatment is initiated. Our initial interim so-called response may not be looked with CT scans or PET scan right away. And the treatment is completed, response is assessed, and then often patients go through a fairly prolonged period of maintenance therapy. This is standard, for example, for CTCL. At any given time, there may be relapse if the patient had achieved a complete response, or progression of disease if the response was only partial. The important thing to remember is that, particularly in CTCL, there will be a progression or relapse at some point, sometimes after many years, in which case the important paradigm to remember is that it's important to loop back to the initial treatment that the patient actually has received, particularly if the response lasted a durable period of time. Because many patients can actually respond exactly to the same treatments that were initiated in the first time, if they responded well. This slide just wants to show the fact that in lymphoma, stage is really one component of the assessment of risk for the patient, and is not the single most important component. Finally, with the advent of molecular analysis of tissue, gene expression profiling, and genetics, now we are in the position of defining different categories of lymphomas based on their molecular profiling, and these categories will respond or not to different treatments, will have a better or worse prognosis. I think it's conceivable that over the next several years we're going to be able to build risk stratification tools that may not take into account stage at all, and just based on molecular analysis. So how do we stage CTCL and mycosis fungoides? This slide shows essentially the T, N, M, and B staging system, which stands for tumor, lymph nodes, metastases, and blood. I already mentioned the different T categories of staging, with T1 patch and plaque less than 10%, T2 patch and plaque more than 10%, T3 tumors, and T4 erythroderma. If you look at the prognosis of mycosis fungoides, really the T category is the most important. Nonetheless, the involvement of lymph nodes, blood, and metastasis clearly adds severity to the disease, and therefore needs to be taken into account. Once you put together the different components of the T, N, M, and B, then you can come down with a composite, essentially, staging system that goes from 1A all the way to 4B. We call early stage 1A all the way to 2A, and all the other stages from 2B on are called advanced stages. The impact that the stage has on the natural history and the prognosis of the disease is shown in this slide right here, which is taken from a study by a British group, which was published just in the past couple of years. Essentially, the two panels, A and B, show what the overall probability of survival over a relatively long period of time, which is about 30 years here, is according to the stage. It's a fairly busy slide, but you can go from the top part with the earliest stages all the way to the lower parts where the stage is more advanced. And you can see the survival continues to decrease with a higher stage. The stage can be described as on the left with the composite staging system and on the right just with the skin, to show that the staging in the skin, perhaps taken individually, is the single most important component of the prognosis. Another important endpoint is progression, which means what is the likelihood that a patient who presents initially with, say, stage 1A, over the course of the next 20 to 30 years, regardless of the treatment, is going to go on to have a more advanced stage. This is shown right here on the two slides, again, divided between the composite staging system and the skin-only staging system. And you can see that over a course of 30 years, even the patients with the very earliest stage, which is called stage 1A, over a course of 30 years, they have up to 10, perhaps 15% chances of progressing over time. In conclusion, learn the words that your doctor uses. We've gone through some of the terminology that you're likely to encounter in the doctor's office. It's important you're familiar with that. Not all the lymphomas in the skin are mycosis fungoides. I showed an example of a patient who presented just with skin involvement clinically, went to the dermatologist, but then the biopsy showed that the lymphoma was unlikely to be mycosis fungoides and prompted further tests, and those tests revealed that the lymphoma actually affected the lymph nodes. In mycosis fungoides, diagnosis remains difficult in early stages. There is no specific marker up to this point or blood test that actually can make a diagnosis in early stages. Multiple biopsies, sometimes up to 7, 8 biopsies over a course of many years, are necessary to make a diagnosis. Another take-home point is that what happens in the skin in CTCL, as shown by some of those survival curves, is 99% of the game. Relapse is the rule, but stage may not change. In other words, somebody may present with early stage mycosis fungoides, get treated, get into a nice remission that may last several years, and then relapse. At relapse, the disease may still be in early stage and therefore can be approached exactly with the same treatment procedures. Finally, it is very important to look back as far as treatment, which is a consequence, again, of this principle that the staging at progression may not necessarily be advanced.